Hello, my name's Dr. Tanya Anastasiadis and I'm the GP Cancer Lead for Tower Hamlets. I also am one of the GPs who sits on the London Cancer Board. Our bid, like the previous two quite similarly, is actually about working together to improve cancer pathways, increase early diagnoses and standardise high quality care. I wanted to share with you just a very quick patient story. She's actually one of my patients, Mrs. P, who's 47 years old. And she presented over several months with vague abdominal symptoms. She presented to 3 different GPs. She attended A&E twice. She was seen in hospital outpatients. All this is before any diagnosis. She had 3 separate diagnostic imaging requests and unfortunately only received her diagnosis when she presented acutely in obstruction with colon cancer in our local A&E department. We need efficient, improved diagnostic pathways such as London Cancer's innovative multidisciplinary diagnostic centre model to improve patient journeys such as hers. And this bid's unique. We've talked a lot about collaboration, but there has been a track record of collaboration in London Cancer, and our approach includes primary care from the outset and commissions from the outset and through the whole pathway.
Thanks, Tanya. I'm Jeff Bellington. I'm Medical Director at University College London Hospitals, and we've been working on this consistently for the last 4 years. We have a collaboration with 11 acute providers, 13 CCGs, and GPs. And over the last 4 years, we have already created a clinical network with replicable structures based around pathway boards, and the clinical specifications and governance structures of these have been bought into by all trusts already. We've already delivered, and we've delivered crucial things. We've delivered a specialist kidney cancer surgery at the Royal Free, as you heard yesterday. We've delivered a prostate and bladder specialist surgery centre at UCLH. And we're also planning further specialist cancer moves across a population base of over 3.5 million patients from North Central and North East London, while simultaneously enabling improvement in codependencies, for example, the trauma service at Barts Health. The pathway boards that we've set up have clinical leadership. They also have patient, carer, and GP engagement, as well as working closely with the third sector, for example, with Macmillan. The model is already helping to reduce variation in care. It will save hundreds of lives, and it can be taken into other areas, both in cancer in other geographies and in non-cancer across other sectors as well. But to do that, we need the impetus of the vanguard status to roll out the following things faster: to improve early access to diagnosis across the sector, to integrate the cancer system further into the community with self-managed follow-up, and to standardize and carte-mark high-quality services and develop joint ventures or franchises or other forms of partnership across the sector. Examples of how we'll do this are: we will be rolling out good practice such as multidisciplinary clinics and straight-to-test, as you heard Tanya saying, is so needed. We want to work through how diagnostic capacity can be even better shared across the sector through new forms and functions, and Julie will address some of that. We will integrate the cancer system with stratified follow-up and patient self-management, making increased efficiency. We'll be creating a cancer outcomes unit with Macmillan, FAR, Cancer Research UK, and work with Cambridge hospitals to benchmark and further improve cancer research, driving improved survival. We will develop a service to deliver chemotherapy close to home, and importantly, develop the standards to carte-mark, give consistency and quality, and thus allow the reproducibility that can translate this to other geographies. We will offer to roll out our radiotherapy collaboration between ourselves and North Middlesex with other willing providers.
Good morning, my name is Julie Lowe. I'm Chief Executive of North Middlesex Hospital, which is a district general hospital in North London. We've been a member of UCL Partners, which is the kind of originator of this Vanguard bid in many ways from the beginning. And we're very, very keen to be part of this particular Vanguard because cancer is such a big part of what we do. As many of you in the room will know, 1 in 2 people will have cancer in their lifetime. And so many of our patients at any given point in time are either under investigation for cancer, receiving treatment for cancer, or increasingly are survivors of cancer dealing with the lifelong effects. And for us, the challenge is how we offer local access to meet the many and very diverse needs of our local population, so that the people that we look after are able to get consistently good quality of care and redress the variations in outcomes that concern us all. Through the Vanguard, I want to give 2 examples of things that we will do in particular and build on things we've already achieved. So a shared workforce for cancer is very important because many of the clinicians that patients with cancer see are highly specialist staff. And the more we can get them to work across the Vanguard, the more every patient can benefit from that expertise. So, for example, our medical physics service at North Mid is already provided directly by staff employed by UCLH, and that has enabled us to move much, much faster in terms of implementing more specialist radiotherapy. We're also increasingly working together to share the best expensive kit that we've all got to diagnose and treat cancer. That helps to get faster diagnosis for patients and also helps to make the best use of assets that are increasingly expensive for all of us to continue to replace and update.
Thank you. Good morning. My name is Pelham Allen. I'm a blood cancer patient. I'm the chairman of London Cancer. I'm also chairman of Bloodwise, which some of you will know better as Leukemia and Lymphoma Research. Cancer patients want 3 things. Early, prompt diagnosis. They want confidence that they've got access to the best treatment, that they really are getting everything that the system can offer. And they want well-managed treatment close to home. London Cancer has developed an integrated cancer system over the last 4 years with extensive patient involvement and from a patient perspective, from pre-diagnosis right way through to post-treatment. We've done that with a board that has delegated independent authority from our partners and from a system of pathway boards, not dissimilar to the system you heard about in South London. But we now have common protocols and treatment pathways for all of our patients.
Sorry, I'm going to need to ask you to wrap up. Thank you very much. Sorry to interrupt you. Can I take questions, please, from the team from the University College London Hospitals? Colleague down here in the black table 17. I'll come to you next.
Is that working? Yeah. My name is Rachel Yates. I'm Programme Director of the Department of Health's emerging clinically led quality and efficiency programme, which I can't say, under Claude Carter, and Chief Officer of the Specialist Orthopaedic Alliance. The question I had was, we've just had 3 wonderful presentations about fantastic work in cancer that are all competing with one another. Surely you should be working together. It should be a national view. There's three lots of fantastic work into perfect pathways. Should it be one programme together?
Yes. Bluntly.
Is it going to happen?
The challenge, certainly, that I have witnessed in northeast and north central London, northwest London, we have 3.5 million people. We have a large number of organisations. We have been able to come up with a number of ways in which changes should be made, better ways of cooperating. It's then taken 2 years to drive that through a consultation process to get the bleeding obvious done. I would love to see a much more substantially coordinated plan across England. It's very fair to say that, I would applaud the Christie's plans warmly, I would applaud the Marsden's plans warmly. We're all basically trying to do the same thing, a strong collaborative approach to these things. We have been doing this for 4 years, so we have actually been through some of those battles. We wear some of those scars, which can be of use to the system. But there is no doubt we should be doing this on a national basis, in my view.
Thank you very much. Colleague on table number 6, please.
Yes, good morning, everybody. Finally have a mic. My name is Nick Bray. I'm actually from the Plymouth area, but I do have questions about this and concerns. And I have to say this is from quite a few of the presentations that I'm seeing. We have patient involvement, but it's almost second-hand. It's coming from various organisations like Macmillan, you've said CRUC here, you've also got the London cancer, blood cancer patients and that, and I'm glad to see you're there, delighted in fact. But are you actually speaking to your patients do you truly know what they want? Because I fear that if you're going to get a second-hand version of that, are you truly understand what their needs are?
I think on a level from being a GP, I hear what you're saying, and I think all I can state is that I believe, being part of the London Cancer Board and being part of one of the actual pathway boards, that actually as an organisation we do listen, and I think if we didn't, I wouldn't be here. I think there's token patient involvement. There's certain words we float around, and I think that if we didn't have patient involvement, we wouldn't have had the successes we've had. And there have been changes because of patient involvement and engagement, like I'm sure there have been in all of our projects. I can sincerely say that we do have the involvement and engagement, and I think it's not just about people saying what they think, it's about people listening. And I'd vouch that we do listen at London Cancer.
Thank you very much. Question on table number 8.
Hi, just good to see another patient. How you doing? I'd actually just like to double up on that question from that guy. Yeah, I am a patient, to answer your question. I don't know about yourself, you're involved in lots of boards. I do work with Macmillan, etc., but an educated voice is still a voice. And I think all three, and yes, we'd love to do this nationally because common sense is hard to find sometimes, but you know, everyone's working in the same direction. Patients are key. We don't want tokenism. Roll out the patient. You know, I might look like a barrel, but I'm not. But I think it's important that we all sort of stick together and work towards it. They're all three good bits. We've all got patient driving us. Obviously, I've been working for 3-4 years in this. I've been living with cancer 13 years. I'm sure you've been living with cancer for a while. It doesn't go away. And I'm sure the problems aren't going to go away straight away. But very sorry to hear about your lady with the colon cancer. That's all too common.
Thank you. Just one final question. We've got 1 minute left. The table number, is it number 12? Thank you.
Good morning, my name is Trevor Clowett. I'm a patient's rep and I'm down from Nottingham. You say that you are you engage with patients and GPs and that type of issues. What I'm trying to do is to explain that the impact of cancer on a patient is one impact, but there's also a massive impact to the family as well, and they have to deal with that. You've not mentioned the family connection as such, because you did mention self-management follow-up, which is a bit frightening to me. Does that mean you're just left on your own and you push it out? The families do need a lot of support just to keep glued together, especially in the early days. I too am a cancer 4 years into, what do you call it, remission? But it's the family as a whole needs to be recognised as a group that just falls apart without proper support. Do you have anything in place for that particular thing?
I completely agree, and the point that I would like to just chip in is a little bit of an anecdote. About 2 years ago at London Cancer, we had an excellent presentation on lung cancer, which was talking about some particularly interesting academic developments that were going to improve treatment at the margin. But we were still losing something over 90% of lung cancer patients presenting with cancer. And my challenge back as the patient was, what are we doing about the 90+% of people? And there was an embarrassed silence, because that's not where the clinicians were focusing. And I said, will you please go away and come back and tell me what we can actually do that makes a significant difference for those people? And they duly did. And we now have an incredibly exciting program coming forward from the academics around improved techniques for early diagnosis of lung cancer. Now, it's not going to get 90 to 10, but it's going to get 90 to 60, a damn sight quicker than was happening before. So I'd like to convey that by having people who have lived with cancer actively involved in our programs, we're able to challenge the professionals in ways that make a real difference. Thank you.
Thank you very much. That's the last question. We now have a 15-minute break for coffee and stuff. Can I have a round of applause for the team from UCLH and Partners, please?